This lecture is on hemifacial microsomia. In this talk, I will give a brief background of hemifacial microsomia. I'll describe the clinical features and imaging appearance. I'll give 3 case examples, and then I'll discuss the imaging differential diagnosis. I will briefly discuss treatment, and finally, I will summarize the key points. Hemifacial microsomia is also known as craniofacial microsomia or otomandibular dysostosis. It's a congenital facial deformity, and it's the second most common deformity next to cleft lip and palate. Typically presents with hypoplastic facial features, most often unilateral, but it can also be bilateral. And it's associated with extracraniofacial anomalies as well. The etiology is unknown, but some people propose that there is a vascular compromise that occurs at roughly 4 weeks of gestation, and there is to date no known genetic cause. The clinical features were categorized using the acronym Almonds in 1991, and I think this is really useful to keep track of the deformities that occur in this condition. O stands for orbit, M for mandibular hypoplasia, E for abnormalities of the external ear, N is for nerve, and it's usually a deficit in the facial nerve. S is for soft tissue deficits. And Almonds Plus hints to the fact that many times there are extracraniofacial abnormalities, and in fact, it has been shown that the more severe the facial deformities are, the more likely there are to be extracraniofacial abnormalities. So I know this is a big table, but the surgeons use this classification system to grade or score the severity of the deformity. And I do think it's actually helpful. You don't really have to know all of this because there's actually not enough on the imaging for you to be able to do the staging. For example, you can't really see the nerve deficit. So, but it is helpful for the radiologist to know what it is the surgeon is looking for. So let's start with the orbit. Normal size and position of the orbit gets a score of 0. And then as you have abnormal size and position, or abnormal size and position, your score goes up. For the mandible, of course, a normal mandible would show a score of 0. A small mandible with a short ramus and a small glenoid fossa gives a score of 1. And then score 2 is separated into 2A and 2B. Both will have an abnormally shaped ramus, but the TMJ will be in a normal position in 2A and in an abnormal position in 2B. And then finally, if there's absence of ramus, glenoid, and TMJ, essentially no articulation, that's score 3. For the ear, it ranges from mild hypoplasia with cupping, but all the structures are present. That would be a score of 1. Absent external auditory canal with variable hypoplasia of the concha would be score 2. And then a malpositioned lobule with absent auricle with just like a lobular remnant left externally, that would be a score 3. And the presence of the middle ear structures is not part of the scoring system, but sometimes the middle ear structures are affected in this condition. Nerve I don't want to concentrate on too much. It's predominantly the facial nerve, and it can be upper or lower branches, and then in severe cases other nerves are involved as well. And with regards to the soft tissue deficit, essentially it's mild, moderate, or severe. So let's move on to the imaging appearance. Essentially, it's the same table minus the nerve because you can't see the nerve on imaging. I suppose with MRI you could, but again, the classification system is really based on the nerve deficit. I'll break it down even further and just say that when it comes to writing a report for one of these cases, I would just comment on the size and shape of the orbit as well as the position of the orbit. For the mandible, I would discuss the appearance of the ramus and the condyle with regards to its size and shape, and I would mention the presence and location of the TMJ, and of course whether or not there is a functioning or the appearance of an articulation. For the ear, I would certainly mention the presence of an external auditory canal or the absence of it. Obviously, they can see the external ear better than we can. And then, although not part of the classification system, I would certainly mention whether the middle ear structures were present and if they were abnormal. Again, unless you're looking at an MRI, I wouldn't comment on the presence of the nerve because you can't see this on CT. And then for the soft tissue, again, just ballpark, minimal, moderate, or severe. Case 1. This was a 1-year-old with left side dominant hemifacial microsomia, and I think that's the appropriate way to term it, is left side dominant, because often the contralateral side is not entirely normal. Looking at the 3D CT reconstruction, you can see the obvious mandibular facial deformity and the mandibular asymmetry with deviation of the chin point to the left and a shortened left ramus condyle unit. But on this slide, I really want to take a look at the orbits. I think the 3D CT reconstructions are pretty good for that. The orbit, I'd say, is a little bit smaller on the left side and slightly inferiorly positioned. This slide demonstrates coronal and sagittal views of the patient's left condyle, and you can see that it's very abnormal. It's shortened. The condyle is abnormally formed, and there really is no glenoid fossa. So this is essentially a type 3 mandible. So this patient also had a type 3 ear, which was essentially just this lobular remnant, which is anteriorly and inferiorly positioned. And this patient did not have an external auditory canal and was also missing middle ear structures. This patient also had a soft tissue deficit. You can see there's a deficit of the subcutaneous soft tissues compared to the right side, and there's also a deficit of the muscles of mastication. That's the masseter muscle there. The next case is of a 7-year-old with right side dominant hemifacial microsomia. Here's the 3D CT reconstruction, again showing the asymmetry of the mandible with a hypoplastic right hemimandible and deviation of the chin point to the right. And I'd say that the right orbit is smaller, slightly smaller, but fairly normally positioned, at least on this single view. These sagittal and coronal images in bone windows through the mandible demonstrate that the right mandible, the ramus, is not only small, but the ramus condyle unit is abnormally shaped. So this is at least going to be a grade 2. And then A or B is whether or not the temporomandibular joint is malpositioned. I think it's in a pretty normal position, although the glenoid fossa is markedly hypoplastic on the right side. This patient's ear on the right was malformed as well as malpositioned, and there was no external auditory canal, but there were at least some middle ear structures present. This slide demonstrates the patient's soft tissue deficit, which included both subcutaneous soft tissues which were deficient as well as the masseter muscle, which was deficient as well. Compare this to the opposite side. Case 3 was of a 20-year-old with left hemifacial microsomia. Looking at the 3D CT reconstruction of this patient, I would say this is a much more subtle deformity than the previous two, and if you're confused as to which side is the abnormal side, look for the chin point. Chin point is right about there, and it's to the left of midline if you were to try to draw a line down the midline of the face. So that indicates that the left side is the abnormal side. with regards to an orbital abnormality, I really don't see one on this view. Here are sagittal and axial CT sections demonstrating the left ramus condyle unit is not only small but abnormally shaped, and the left temporomandibular joint is hypoplastic, although there is an articulation, and it seems reasonably positioned, although it may be a little bit anterior. This patient had pretty normal external ears, had a left external auditory canal, as well as middle ear structures. Despite the bony abnormalities not being so severe in this patient, there was a marked soft tissue deficit with almost complete absence of the masseter muscle on this side. The imaging differential diagnosis includes Treacher-Collins syndrome, Perry-Romberg syndrome, also known as progressive facial hemiatrophy, and condylar hypoplasia. Treacher-Collins syndrome is bilateral and it's very symmetric, which differentiates it from even the bilateral cases of hemifacial microsomia, which are not perfectly symmetric. In addition, the most prominent deformity in Treacher-Collins syndrome is hypoplastic zygomas, often with absent arches. While hemifacial microsomia may have hypoplastic zygomas, the mandibular hypoplasia is more prominent. Clinically, patients with Treacher-Collins syndrome will not show nerve involvement, and patients with Treacher-Collins also are missing eyelashes on the medial thirds of their lower lids. That's what I've been told. Perry-Romberg syndrome, again, this is not congenital. The history would distinguish this from hemifacial microsomia. Also, Perry-Romberg syndrome has intracranial manifestations, and hemifacial microsomia does not. Finally, condylar hypoplasia has many causes, but most common is prior trauma. It's not congenital and does not have soft tissue deficits. However, if the condylar trauma and the subsequent growth disturbance occurs really early in life, before the growth of the midface, the orbit and maxilla can secondarily be affected. So if the ramus condyle unit is short on the side of trauma, this could prevent the downgrowth of the maxilla and orbit if it occurs early in life before the orbit and maxilla have finished growing. I want to take a moment and just discuss the controversy over the appropriate treatment for patients with hemifacial microsomia, because I think it's kind of interesting. The first question is whether or not the maxillary deformity is primary or secondary. And what I mean by that is it just part of the condition that whatever event took place in utero leads to hypoplasia of the mandible and the maxilla? Or is the maxillary deformity secondary to the mandibular deformity? And this leads to the second question: does early intervention help to minimize the secondary deformity? So if you believe that the condylar hypoplasia and the lack of growth of the ramus condyle unit on the affected side prevents the downgrowth of the maxilla and the orbit, then if you can intervene and lengthen the mandible on the affected side early, you could give room for the maxilla to grow and prevent the secondary deformity of the maxilla. And that is what some surgeons do. They may use distraction osteogenesis or other techniques to lengthen the short side early in life, maybe when the kid is 6 years old or so, and just allow for the growth of the maxilla to try to prevent a more severe end-stage deformity. Other people feel that that doesn't really work, that the orbital and maxillary deformity, it's just part of the condition, it's going to happen, and you should just let it all happen. Don't perform surgeries on little kids, and when they're fully done growing, then do one surgery at that time and fix everything all at once. So I think it's kind of interesting. I don't know if it's well known. Certainly in cases of condylar hypoplasia from trauma, we do know that that can cause a secondary deformity, but it's unclear whether or not in hemifacial microsomia the maxillary deformity is primary or secondary. Here are the key points. Hemifacial microsomia is a congenital facial deformity, and its clinical presentation can be summarized by the acronym Almonds, again standing for orbit, mandible, ear, nerve, and soft tissue. Remember that unless you're looking at an MRI, you can't see the nerve deficit on imaging. It's really important to document the external and middle ear deformities, even though the middle ear deformities are not part of the classification system. Take a good look at both sides. One side is often more abnormal, but it would be important to not miss an abnormality on the less affected side. You should also know that various extracraniofacial anomalies are associated with this condition, and the more severe the facial deformity, the more likely there is to be extracraniofacial anomalies. And there's a whole host of anomalies, renal, cardiac, and other skeletal anomalies that are associated with this condition. And then finally, treatment is controversial, specifically the timing of treatment and whether or not early intervention can minimize the end-stage deformity.